Thank you, Sig, so much. I appreciate that very nice introduction. And obviously, as you all know, it's been great being initially in St. Louis for 25 years and having a friendly competition and rivalry with UCSF for spinal deformity programs. Certainly, I think we both centers push each other to be better and take better care of our patients and raise the bar academically as well. So thank you for that. And now we moved a little further east to continue that competition. So now being in Columbia, New York City. So it's amazing. This is my first in-person meeting since January 2020. So for someone who used to travel more than I wanted to, it's been nearly 20 months since I've been to an in-person meeting. So this is wonderful. Great to be here this morning. So I've got a bit of somewhat of an esoteric talk. So the first question I have is raise your hand if you've done a VCR for any type of deformity in children or adults the last 5 years. Just raise your hand so I get a feel for that. So about maybe a third of people in the audience. Okay, that's not for everyone. But so my goal here will kind of explain why we do still VCRs, especially if we're focusing on just on children and what are the alternatives. And if we're going to do this, how can we do this more safely? Obviously, it's the key number one is always safety in the operating room. So get this to work. So what am I doing wrong here? There we go. So I do have substantial royalties from Medtronic. Ooh, now it doubles up there. So go back a second. Royalties from Medtronic is my main disclosure. All right. So let me see if I can do this. Just one click. There we go. So obviously severe pediatric deformity comes in many shapes and sizes. In the last 30 years, I've taken care of a lot of very deformed children who obviously, and it's very rare, I don't think I've ever told a child that we cannot help them with surgery. We definitely tell adults very routinely that for whatever reason, we're not going to be able to help them with a major deformity surgery. But in children, that's not usually true, including having a patient in traction for 11 months, I think was my record, before the patient was healthy enough to have surgery. The next patient did not actually have a VCR, interestingly enough. So VCR is, again, removing an apical vertebrae. They're separating the spine into two sections and shortening the spine at the apex, which relieves tension on the cord, which really is one of the key to this operation. I've got a fair amount of experience doing this, and I've also, as Sig mentioned, tried to educate others as well on how to make this surgery as safe as possible. So the spinal articulation and apical shortening is really the key, and when we need to shorten the apex is the key to me right now when we need to do this operation. So it's been, I think that there's a very specific population that needs exactly this operation, at least in my hands. It is high reward. Some of the most dramatic corrections I've ever obtained is from a VCR, but it's also high risk, obviously, because we have to circumferentially dissect often 6 spinal cord, because, again, it's going to be the cord's tight at the apex and the blood supply is often very attenuated there, so it makes it higher risk. So in 2000, after visiting Professor Suk in 1998 and seeing him do a few of these in Seoul, Korea, I was sent this patient from Moscow, Russia through the Shriner system, put the patient in traction, and did a 2-stage posterior-based VCR, and was amazed at kind of how she did clinically and radiographically, especially clinically. She did extremely well with this, and that started my career with doing VCR surgery. So by 2008, I'd done over 100 VCRs, and I published a series of over 60 pediatric specific VCRs for patients like this. A 10-year-old that had, I believe, 20 prior surgeries, what I call failed growth-friendly surgeries, and I ended up doing a 2-level VCR for this patient. See the radiographic clinical results for this type of surgery, so quite dramatic, especially in the revision population. And I also convened shortly thereafter a group of other senior pediatric surgeons doing VCRs to kind of figure out how we were all doing with this, how risky this is. And what we found is that we had a fair amount of intra-op complications, but a lot of these were loss of spinal cord data or actual spinal cord and nerve root deficits, but most of those were temporary. Only one patient in this whole series of 147 had a major motor neurologic deficit. There were no permanent paraplegics. So although risky, most of these children at least recovered quite nicely from this type of surgery, which was good to see. So to me in 2021, kind of absolute VCR indications for severe pediatric deformity include a 3-column spinal fusion, either congenital or iatrogenic residual deformity, where again the spine is fused both front and back. And I'll show you an example of that, where the best way to approach this is just off in the back to resect things. High degree of angularity to the spine, especially with myelopathy, and I'll show you examples of that. That's probably right now one of the most common reasons I do a VCR. And some just really strange esoteric deformities. I'll show you one on how we prepare the patient for this kind of surgery or a combination of the above. So this kind of patient who presented to me actually after being seen in Boston Children's and being offered a anterior and posterior surgery and ECMO in between because of horrible PFTs. You see the congenital fusion both circumferentially with a severe thoracic lordoscoliosis causing severe restrictive lung disease. The best way to approach this is posteriorly, where we can correct the scoliosis, create 50 degrees of kyphosis here, and the patient got extubated the first day after surgery and was out of the hospital within 4 days. This is definitely a better way to go than putting someone on ECMO and trying to go to their chest with such limited pulmonary function. Second one is the most common indication for me to doing a VCR is someone with myelopathy. So here's a kyphoscoliosis NF patient with myelopathy. You see this sagittal deformity angular ratio. We kind of quantify radiographically the number of vertebrae involved in the Cobb measurement. This patient's already had anterior and posterior fusion surgery times 4. So the DAR, again, to be published, is the angularity of the spine in the coronal and sagittal planes. And DARs over 15 to 20 start getting into the range of being very angular and having the cord tented over the apex of the deformity, which this patient is. So this cord's at risk with any kind of surgery, obviously. The blood supply is going to be attenuated anteriorly. They often get what we call ribbon spinal cords. No matter what you do with this patient, there's going to be a high risk. So we try to quantify not only the angularity radiographically, but we've also now quantified the tension on the spinal cord through this spinal cord shape classification system that we just published, type 1, 2, and 3. I like the rule of 3s. I'm a very simple guy, so rule of 3s always works well for me. Type 1, there's basically CSF around the cord at the apex. Type 2, the cord is touching the body, pedicle, or lamina posteriorly, but not deformed. Type 3, the cord is already deformed at the apex before you even start your surgery. Obviously, not surprisingly, in our study and other groups have repeated this, a much higher rate of having spinal cord monitoring changes with a type 3 cord, no matter what you do. VCR, no VCR, doesn't matter. You're going to be much higher risk when you're starting out with a deformed spinal cord, probably with an attenuated blood supply before you start your surgery. In our hands was 28 times higher risk of losing data intraoperatively with a type 3 cord. Just wanted to highlight that additionally, I designated a type 3M, so a type 3 cord with pre-op myelopathy. You see this patient, see the crescent moon-shaped spinal cord. This patient could barely walk and had severe myelopathy pre-op, obviously as a resultant of their highly tented spinal cord. So not surprisingly, when we doing these and actually didn't have any major neurologic deficits myself, I started doing more complicated patients like these, with, at the time, type 3 cords, which I didn't really truly understand the definition of that. But I had patients wake up with post-op paraplegia. I had 4 patients actually. And all 4 patients had severe angular kyphosis, all had pre-op myelopathy with prior anterior fusion with segmental vessel ligation, i.e. poor blood supply to the cord, all in the kind of watershed area, T4 to T9 apex, very dangerous area of the spine to work on. None of them had spinal cord monitoring possible. There had no signals from the start because they're myelopathic. They could move, most of them could walk, but their spinal cord was so attenuated that we couldn't even run electricity down it, which is obviously a bad sign. So all 4 of these patients woke up paraplegic. It was devastating. But I realized that over time, and all 4 of these recovered, 3 completely, 1 to be able to walk, but not normal over time. But I realized these are the patients who need VCR surgery the most. Without surgery, they're going to become more myelopathic and eventually end up probably wheelchair bound. But I believe the risk is the patient pathology more than the VCR itself, honestly. Once the cord is decompressed and everything is done well, the vent cord ultimately recovers, especially if you do a nice atraumatic surgery. But for someone like this, again, who has a very bad prognosis without surgery, obviously, doing a 3-level VCR for spinal cord decompression and then deformity correction gives this type of radiographic. And so again, this is what I call a ribbon spinal cord. This is this patient's spinal cord intraoperatively before we push the 3 levels of vertebra off, eventually off the cord. This is what I call a ribbon spinal cord. There's no dural pulsations. It really is 3 to 4 millimeters thick cord tissue. Then we basically push the posterior wall ventral, obviously. Next slide, please. We get to this, and this is a video, please. If you can run the video, you can now see the actual dural pulsations that occur. And this patient basically had monitoring come back after this decompression. So no monitoring before this. Monitoring actually comes back. They wake up neurologically normal. So that happens often as well in this kind of cases. So this is the kind of clinical result from this kind of surgery as well. So again, pre-op myelopathy, angular deformity, type 3 spinal cord. These are the patients that I'm looking at. You have to shorten the apex. You have to take the tension off the cord before you do any deformity correction. Often we precede this with halo gravity traction, obviously, especially in children, for other benefits, as I'll show you. But to me, this is still a good indication to consider a VCR. Next slide. So we have up to 5-year follow-up now. I think Mike Kelly, he reviewed my patients at WashU would have 5-year follow-up of VCRs. Next slide, showing very not only good radiographic correction, but most importantly, excellent outcome scores being maintained at 5 years post-op with significant improvements in almost all domains of SRS scores, as you can see here, especially in, interesting, the self-image is the greatest improvement, which is not surprising. Next slide. So how about some tips pre-op? Next slide. So the key is optimize these patients, especially children. These children are not healthy typically. When they come in with these severe deformities, they're all very thin. Their work of breathing is so high that they're expending a lot of energy. So almost invariably they're thin, nutritionally depleted, and the respiratory function obviously is very poor as well. So we put them on a training program, often in hospital, actually, especially when I was at the Shriners. We did this very routinely. I think my record was having 8 patients at one time in the hospital in halo gravity traction. Now I typically only have 1 or 2 at most, but we still do this. We publish the results of this that not obviously giving the spinal column a little bit of stretch. Intuitively, we're also putting a little tension on the spinal cord, and spinal cord adapts well if you do things slowly to it, right? So you stretch it out slowly, gradually with them awake, you can get a fairly amount of elongation, even in angular deformities, and they will not cause neurologic issues. If anything, I think it toughens up the spinal cord and probably gets alternative blood supply pathways in the 6 weeks or so you're putting in traction. So I really like traction for these severe deformities, especially if they're myelopathic. That's a good indication to do traction. Next slide. Again, we'll consider nutrition, so G-tubes if we need in these patients. Again, you see the difference even in traction in this patient. The patient's not had surgery yet. You see the improvement clinically with probably 6 weeks of traction or so. Next slide. And I'll just take you through a very severe deformity, kind of how we use this to make patients healthier. We spend time on the pre-op end to avoid problems on the post-op end. These obviously are high-risk patients. This is a very esoteric patient with a very severe, almost immeasurable kyphoscoliosis. Next slide. Where in the pre-op model, think about this, the T2 to L2 distance is 2.5 centimeters. So think about that. So where is the heart and lungs in this patient? I'm not quite sure. Next slide. So here's the pre-op PFTs, pre-traction PFTs, 33% FVC, 26% FEV1. This patient's going to stay intubated post-op, may even get a tracheostomy if we just take the patient to surgery right now. So we don't do that. Next slide. Put them in traction. So here's the 6 weeks of traction, 40 pounds ultimately, almost more than half body weight. We get 8.5 centimeters in height gain from this. Next slide. Here's a sagittal plane. You see there's a downgoing proximal thoracic radiographic region. That's a bad sign, right? When important part of the spine caught at actually is more distal than the cephalad portion. That's a bad sign. But now we get the proximal spine more vertical, right? So we can actually get access to the proximal thoracic vertebra for screw placement. You can't get screws in the far X-ray on the left. Your skull's going to be in the way. Next slide. See the weight gain, 77 pounds to 88 pounds over 6 weeks. Next slide. And here's the clinical appearance. Obviously very deformed, but now we have a manageable deformity, right? After 6 weeks of traction, radiographically, clinically, nutritionally. Next slide, and I think we have the PFTs result now here, 54 and 42%. Now this patient can have surgery, and if everything goes well, they'll get extubated either in surgery or the next day, which he was. He got extubated the next day. Next slide. So again, we put time on the pre-op end to get these patients healthy to be able to do this 3-level VCR. And he had myelopathy as well for correction of this severe deformity. Next slide. He was discharged within a week post-op and no post-op complications. So again, doesn't guarantee uncomplicated post-op course, but it kind of makes sense that if you get these patients healthier for these kind of surgeries, you're going to have a better outcome post-op. Next slide. So the other thing that I do that's extremely important to me, and I still do up to this day after still in 30 years in practice, I make 3D printed models of all these patients. That's my pre-op assessment and intra-op navigation. Next slide. There's a video here. So again, I make this and I study it. I put little dots where I want to start my pedicle screws on. I study the anatomy posteriorly and anteriorly because I can't see anteriorly. I mean, you can use navigation, that's fine. But I understand this even before I go to the OR, exactly what I'm doing, what my plan is, and I understand the osseous anatomy. And I can coordinate this obviously now with the neural anatomy inside on the MRI. Now we have other ways of doing this with surgical theater. We kind of create 3D models that has the spinal cord inside of it as well. So the key is just understand the pathoanatomy, right? The better you understand that, the safer you're going to be in surgery, and the more time you can spend on other things that will come up in surgery, like fixation and construct mechanics and closures and things like that. Because I'm not worried about the anatomy. I understand anatomy before I go to the OR. You should not go to the OR in these cases unless you fully understand the osseous and neural anatomy. Next slide. So intraop tricks, I think next slide is a video, kind of show a VCR, a minute VCR for in a schematic here for scoliosis. Obviously after incision, we expose the spine very thoroughly, do our inferior fasciectomies, and put our screws in at every level except the single level VCR apex here. And the first thing we do is take the 2 little ribs going to that level we're going to resect. And I do a very, very little rib excision now, much less than I used to. Put a temporary rod on the convexity, and then basically drill out and do a wide laminectomy, going to inferior level above, superior level below, exposing the cord. And then basically I like to take out the concave pedicle early. So I basically protect the spinal cord and drill that out. And that takes tension off the cord immediately. And you'll see the cord actually drift over just like that. And now you can actually compress a little bit more, which take a little more tension off. I'll continually compress. Put temporal rod on the left side. Sometimes I even keep the temporal rod on the right side if I can. And then now I'll do the convex dissection, which is the majority of the dissection because the body obviously is rotated up in the air and on the convexity. So you protect the vessels, remove the TP, the pedicle obviously in the body, save as much bone as possible for bone graft. It's obviously very good bone. And obviously protecting neural elements. On the convexity, you have a little more leeway now because the cord's drifted over towards the concavity. So that's why I like to do that first. We have a posterior wall impactor, then comes in and removes the posterior wall as the last part of the bone to be removed here, pushing that ventral. And the cord's completely free now circumferentially. So the first thing we do is on our convex side, shorten the spine. That we always do that as a first maneuver for VCR closure, is shorten the spine, take tension off the spinal cord. And after we shorten, then we can lengthen. So we go back and forth, compression on the convexity, distraction on the concavity, back and forth over multiple times. Switch temporary rods out to permanent rods and do more in situ contouring and other maneuvers to be able to straighten the spine, making sure that there's no tension on the cord. Obviously, as much correction as we can get based on a variety of factors, including screw purchase and things like that. Always fill the anterior gap with a cage. Even if I can get bone on bone, I like a cage because I like the interdigitation of the tines of the cage for rotational stability more than just a slippery bone on bone. Obviously, I can't forget our fusion here, including covering the laminectomy defect with ribs, either autogenous and allograft ribs for both covering of the dural sac and osseous fusion. And now obviously we're doing either 3 or 4 rods on these cases as well for additional support because we just cut the spine in half and there's obviously more instability in that area. So I got a minute video of about a 10-hour surgery at times. So next slide. Obviously, we're always using antifibrinolytics. I think this has been nicely shown. Again, our Fox study group showed this very nicely, that a significant decrease in blood loss when we use antifibrinolytics like TXA than when we didn't. So that has to be standard of care. Next slide. Use it typically at 50 and 5, 50 mg per kg load, 5 mg per kg per hour maintenance the whole surgery. That and a protein basically changed my life as a deformity surgery. Back in about 2000, we started using a protein. I don't know if any of you worked without antifibrinolytics, but basically you cut your blood loss in half when you use antifibrinolytics, which is so nice in this and especially adult surgery. Next slide. Other correction techniques, and I won't get into too much detail here, but one thing I want to point out, one of the first decisions that I make for correction is whether I'm going to do individual screw correction or construct-to-construct correction. So you have to decide that. Because again, it is messier to put kind of construct in with dominoes and things like that. But if you have, and I'll show a case of this, softer bone or fusion mass bone, it's very hard to manipulate a single screw in a fusion mass. You're going to plow that screw very quickly. And you have to maintain screw purchase in these cases. Otherwise, you have a very unstable spine. I've unfortunately been in this case, really, I'm holding the spine, limbs of the spine together when my fellow's putting the rods in because I lost purchase on my screws. You don't want to get there because the spinal column really is very unstable after you cut someone in half like this. So you don't want that to happen. So next slide. So a kind of case where I'll do individual screw correction is this kind of case, AIS, large curve, but overall good bone. Next slide. You see we have our good screws in. We got concave reduction screws, convex large 6.5 to 7.0 screws, really good purchase every level. So basically I'm going to do this correction on screw purchase alone, individual temporary rods, no connectors, no devices, convex rod first, concave rod second, compressed distract like I showed in the video, and this will work out well. It's got to have good purchase. It's a primary case, and again, this can do well with convex compression first, next slide, concave distraction second, next slide, inside to contouring, next slide, inside to contouring and translational plane third, next slide. To get this kind of result, again, using only temporary rods without any connectors or dominoes, and much simpler to do, but again, you have to have good screw purchase to do this. You can see, I think the smallest screw I used here was 6.5 diameter, so we can still, we got to fit and fill the pedicle as much as we can. You got to get good screw purchase, and that's something that we don't talk about for deformity surgery, but to me, the most important part of deformity surgery is getting a really, really solid screw, even more important sometimes than the osteotomies. I think the fellows who worked with me know that, and we really want to get good screw purchase. This can give this kind of radiographic results 5 years post-op, next slide, and clinical results without any thoracoplasty. There's no thoracoplasty down here. This is all just spine correction from the VCR. So just tremendous correction without thoracoplasty. Next slide. This kind of case is different. Patients see 5 prior surgeries, post-5 posterior, 1 anterior surgery. You see the fusion mass posteriorly and anteriorly. You see the rotation there. That's a true 3D rotation there. The spine's rotated more than 90 degrees. So you could basically dissect posteriorly right into the foramen. So you have to understand that obviously ahead of time. But there's no way you could put individual screws, cut the spine in half, and take it together. You're going to need to do construct to construct correction. So the row screws above, row screws below, then bring them together with a domino. Next slide, I try to simulate this kind of schematic. So you have row screws, either 3 or 4 above, 3 or 4 below, and then you join them together, join the rods together with dominoes, and you basically, in this kind of case, since it's a hyposcoliosis, you're going to compress the convexity. And you'll do this 10 times, click, 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 4 or 5 millimeters at a time, stop, run a motor data, come back, do it again, so it's back and forth, because you just got to let stress, relaxation, and creep kind of catch up with your correction methods here so you don't loosen your screws. But when you have a group of screws above, a group of screws below that you're using in concert, obviously you're much less likely to plow that whole group of screws. So again, these kind of cases, as an example, is best done through construct compression and even distraction. Same thing on a concave cavity. I'll distract through dominoes a group of screws to get better correction. Next slide on this kind of case. So here we have 2-level VCR, T1L for radiographic correction, next slide, and clinical correction as well, this kind of patient. Next slide. So again, using more than 2 rods, I think I was one of the first surgeons to promote this, and by 2014, I had 132 consecutive 3-column osteotomies in kids and adults with 2 versus multi-rods equally distributed, amazingly, 66 in each group. I had no idea that was the case, but all had 2-year follow-up, and not surprisingly, the 2-rod group had much more rod fractures and pseudos with return to the OR for repair versus the 3 or more rods group. I certainly have revised a couple of BCRs and PSOs with 3 or 4 rods, but nowhere near the rate of a 2-rod group. And I think that's become standard of care also to put more than 2 rods in either PSOs or VCRs, and I'm a firm believer of that as well. Next slide. Again, I mentioned cover your laminectomy defect. I had an unfortunate patient in St. Louis a long time ago where we closed up the wound. Everything was fine, basically, and actually my fellow and resident closed up, and we stopped monitoring data, turned the patient over to end the case, no movement in the legs. We basically pushed down on the dural sac with the fascial closure. I had no covering over the dura. So you always want to make sure that if the most dorsal element is in your spinal cord, right? Because that happens sometimes in kyphoscoliosis when you correct these cases. So I always put something, either bone, obviously, would be ideal for not only covering but healing. I've used cut harms cages, meshes. I mean, there's all kind of things you can put, but you want to make sure that something's covering the cord from rod to rod, that it's not the most dorsal element, so your muscle and fascia won't press into it. Next slide. So again, optimal screw purchase, go slow. I always have 2 temp rods in place when severe deformities that are very angular. I have more than 1 temporary rod. I've had patients sublux even off 1 temporary rod, so I always have 2 rods, 1 on each side, and I'll keep 1 as a tracking rod. Usually the concave rod is a tracking rod. The set plugs are loose, so I'm correcting through the convex rod, which is closing things, but it is an anti-subluxation rod. So maintain correction. Once you get things corrected to a better state, you obviously have to maintain that correction. Dual-headed screws work great to that. You can kind of swap in and out temporary rods, or hook rod constructs. Temporary hook rod constructs work great to hold your correction, especially on the convexity, until you switch out your permanent rod, where you use a lot of cantilever and push the convexity down with your final permanent rod to get cantilever correction, which worked very nicely as well. Next slide. So do we need stage these or not? And honestly, I stage these as often as I used to, even though I'm probably more efficient doing these. I still stage these when I need to. And I luckily found when I published this a while ago, no difference in complications, at least in my hands, in one-stage or two-stage surgeries. Now, in all fairness, the ones that are two-stage are probably more complicated. So you would think they'd actually have a higher complication rate, but they didn't. Because again, we're not doing the VCR at 5 o'clock in the evening when the patient's a little coagulopathic and you're tired, anesthesia's tired, the patient's tired. So that's why, basically I can't get this done and closed within 11, 12 hours, then I'm doing these in 2 stages. Next slide. But again, every case is different. So here's a patient, Sherman's kyphosis, 4 prior surgeries, deep wound infection, implants out, progressive deformity, both regional and global. Next slide. So you see part of the spine's fused, part of the spine's not fused. The fusion actually goes all the way to the cervical spine. Next slide. Big boy. There's a lot of dissection here. So just exposing the spine and closing, it's going to be 3 hours on this, right, to do a good closure, especially when you get the plastic surgeons involved, which I do, and I'll mention that later. So they take a long time to close, but they do a really good job. Next slide. So this we all do in one day. This takes 13 hours, but he's got a big blood volume. Everything goes fine. We get everything done with an L1 VCR here, cervical to sacrum instipation fusion. So a long day, but again, it's better to take this kind of patient in one day, because opening this wound up a week later and closing it again is not ideal, right? This or myelose, things like that. Next slide. So luckily his wound healed fine, and because again he had a big blood volume, he was otherwise healthy, he can tolerate this much surgery. Next slide. This patient's different. 17-year-old Noonan syndrome, 4 prior spine surgeries, 2 heart surgeries. She's thin, she's not healthy. There's a lot of work to do in this patient. Next slide. She's off in the coronal and sagittal plane. She's got prior surgeries here, fusion masses, got some pseudos there. We got a lot of work to rebalance her in both the coronal and sagittal planes. So I separate this, next slide, in 2 surgeries. Here's the first stage, L1 VCR. I work mainly in the coronal plane here. Use kickstand techniques, compress on the convexity of the VCR, distract on the concavity, slowly with the kickstand type mechanism. So we get her realigned fairly well in the coronal plane. Is the first stage. Next slide. And second stage, we come back and take care of the sagittal plane with PCOs to correct her sagittal kyphosis. Next slide. And here's her final results. Again, 2 separate surgeries, much better for her and for me, just to get this patient optimally corrected with less stress of, again, working late and trying to put everything together in a very complex situation. Next slide. And a little shout out to the plastic surgeons. Again, I'm very aggressive using these now, even more so than St. Louis. And this kind of patient is almost essential. 19-year-old meningocele patient, previous posterior and anterior surgery at age 9 with progressive lumbar hyperlordosis with a solid fusion anteriorly and posteriorly over her meningocele levels. So very complex problem. You see that big skin crease there. Next slide. So here she is taped and maximum hip flexion on the OR table. And you see the gully there. So obviously you see we have tissue expanders placed by the plastic surgeons because we're going to elongate her skin. There's no way we're going to get her closed if we can get her corrected after this. So we need their help for this, obviously, to get her closed after her correction. Next slide. So here she is before and after. Again, a single-stage surgery because, again, getting her closed twice would be a trial. Luckily, she was fairly healthy, so we can get this all done in one day. Next slide. So basically did an L5 PSO, kind of really more of a VCR, but her apex was actually so deep in a hole, actually I disconnected her in L5 and then distracted slowly after I released all her nerve roots, did a complete laminectomy L1 to L5 and have her entire cauda equina nerve sac migrate dorsally as I distracted her. And she actually had no neuromonitoring changes. So we got her nicely corrected. Next slide, and importantly, her wound healed perfectly with the plastic surgeon's closure. So again, get plastic surgery involved in these, especially at the end of the day, you and your team is going to be tired, so they're fresh and they do a great job. So definitely a plug for them. Next slide. Alternatives to VCR, this is probably the most important part of the talk. When do you not do a VCR? Next slide. So here's my 3-column experience last 20 years. So purple is PSOs, orange is VCRs. You see there's less 3-column osteotomies I'm doing, I can guarantee you I'm not seeing less complicated patients in New York City. I'm seeing more complicated patients, but we're managing these patients differently, especially PSOs. We all know that all adult surgeons in the audience know that. We're doing much less PSOs for adult deformities, and same thing with VCRs, although I'm actually kind of already done 12 VCRs this year, and this year I'll probably end up doing 20. I've got 10 more planned already, so I'm probably gonna have a bit of a spike, but again, just because I'm seeing more circumferentially fused patients and more patients with myelopathy, so they're gonna get more VCRs, but on average, much less, and certainly not a peak of 35. I'm not gonna do that anymore probably. Next slide. Because we found we can do a lot with multi-level PCOs and sometimes just apical patelectomies if we need to take pressure off the cord and not do a complete VCR. So I'm doing that more often. Obviously, temporary internal distraction. Dave Skaggs here, that works very well for cords that can tolerate that, right? And periapical PCOs and fusion mass translation, I'll show you, works very well. And sometimes you just have to accept the fact that you can't make the x-rays look perfect, but that's okay if you do this safely, and you still get quite good corrections with this. Next slide. But for severe idiopathic sclerosis and a patient, and then show the MRI, she has a type 2 cord at the apex, so she can tolerate a lot of distraction, a lot of lengthening of her column. Next slide. So we just do multi-level PCOs and get certainly adequate deformity correction without any VCR work here for this double major large stiff curve. Next slide. This kind of patient has a post-laminectomy, severe scoliosis with a bit of proximal thoracic kyphosis. That's where her laminectomy is. She had a previous intradural tumor removed, so very high risk. Next slide. So this patient goes in traction first. See, we elongate her spine. She's a type 3 cord, so obviously a little bit at risk. So I'm going into surgery, possibly doing a VCR, possibly doing a patelectomy. Next slide. But also all we did was basically do periapical PCOs, covering her PCOs with a temporary rod before I loosen her up. So I put a temporary rod on convexity. Then I do my PCOs, and then we just squeeze the convexity since she's kyphotic there and take the kyphosis out and translate her over and get probably more correction I would have with a VCR, which much less risk and no change in her monitoring data. So again, just depends on what the cord can tolerate, understanding the cord pathology beforehand, the type of deformity. Lordoscoliosis, it's hard to compress. You're going to make the spine more lordotic. So lordoscoliosis, I'm more likely to posteriorly translate, which lengthens the cord, which means you have to shorten the apex. So it just depends on what's going on at the apex of your deformity, what technique, at least I'm going to choose to correct these kind of patients. Next slide. And these kind of patients where the physical health of the patient's not ideal. So here's a patient from Texas I treated in the last few months. Congenital kyphoscoliosis, had vectors, solid fusion T5 to T12, poor cardiac status. He actually was on hospice because of his cardiac ejection fraction was less than 20%. But medically, they got him up to 40%, and the cardiologist, Texas and cardiologist at Columbia thought we could treat him. So basically, I put him in traction for a while. And then next slide. Ended up when I call a periapical PCO and posterior translation maneuver. So his apex was so rotated, and again, it was pretty unhealthy. So to take his whole spine and chest wall apart would have been a lot of work. So what I do is basically spare the apex, and I cut the spine up above and below. So I do PCOs periapically, and I leave the entire fusion mass intact in the apex. And basically, I take correction maneuvers where I just push that apex medially and ventrally. It's because it's a kyphoscoliosis. Next slide. So here's the end result of this, basically. So obviously a complicated case. We had to go all the way to sacrum and pelvis on him with multiple rods. But basically, we get marked correction of the spine, and there's no VCR. There's actually, the apex is still fused over probably 6-7 levels, but we just translate the whole apex eventually immediately, again, by doing periapical PCOs and a lot of cantilever. So you have to have really good screw purchase, obviously, on top to do that. So your top left screws don't pull out. So I went to C7, and you see the C7 pedicle screws and really good screw purchase to be able to push the spine ventrally immediately for his deformity correction, and did this over 2 days because, again, his tenuous cardiac status, and he tolerated well and did fine with this. So again, just other options, and I do this in adults fairly commonly that are previously fused. I'll cut up the apex periapically, not at the apex. Doing PCOs of a curve that's rotated more than 90 degrees is very difficult because the cord is resting on the concave pedicle, right? Immediately, it's very hard to do that. PCO, you're way deep in a hole. It's very dangerous. So I'd leave that alone. I cut the spine up where it's more visible, where the spine's easier to access, and then I push the whole apex ventrally. It tends to work out very well. I do this very commonly now. Next slide. So hopefully I've been able to explain that VCR is at least I use VCR now in 2021, these severe fixed angular deformities with or without myelopathy. Powerful correction, but challenging for both the patient and surgeon. Tips and tricks are now widely known, hopefully in practice, to ensure safety for anyone doing these. And obviously alternatives are still widely used and should be used. This really should be the procedure of last resort when nothing else more simple would work, because this is obviously still a very challenging procedure. Next slide. And thank you for your attention.